I want to give you a practical application of some physiology that you can use at your patient's side to improve outcomes. And this is a situation that we face not infrequently, where we have a patient who is in respiratory failure, but also in decompensated shock. So with some low blood pressure, unstable vital signs, etc., also requiring airway management. And the issue there is that things that we do to manage that airway can actually have unintended consequences to our patient's hemodynamic status. And I want to walk you through quickly how that works and give you some thoughts on what you can do to potentially stop the decompensation from getting any worse. And so this begins with a discussion of how you get blood from your toes back to your heart. Well, a lot of people think the blood pressure that's moving blood down through your body is enough to lift that blood back up. And there is some pressure that lifts, but really you also have a secondary mechanism. And that mechanism is when you contract a muscle in your leg, you put pressure around the vein, and because veins have one-way valves in them, it squeezes the blood up, it can't fall back down, and it's like an escalator. This is why, if you've been in the military, you know when you stand at attention, you have to rock your knees, otherwise, eventually, you're going to fall out. It's the same reason the kids in their elementary school recorder concerts stand there on the bleachers or the risers, and after about 15 minutes, they all start falling over. It's actually also the same reason why you need to move your legs if you're on a long car ride or plane ride or anything like that to prevent yourself from getting DVTs. Because without that muscle movement, pushing that blood up that escalator of the veins with their valves, you will end up with stagnation of blood in the lower extremities and the potential for development of DVTs if it lasts long enough. So that secondary mechanism of lifting blood up is another way that you get blood back to the heart besides just the pressure of the blood. But it turns out there's actually a third way, and the easiest way to show that is actually to draw it. And it looks like this. So here's our chest cavity. Here's our lungs. And we have a couple other things that live in the chest, right? We have our heart. And we have big red, the aorta. And we have big blue, the vena cava. And if you remember, when you take a breath, you generate negative pressure in the chest by contracting your diaphragm down. And that's what pulls the air in. But remember, just like we talked about springy and floppy walls in airways, arteries and veins also have springy and floppy walls. And if you generate this negative pressure inside the chest on the outside of this floppy vena cava, you are also going to draw some more blood back into the chest as you take a breath. The problem is when we come along and start pushing the air in instead of the patient sucking the air in, we then put positive pressure in the chest. And if you put positive pressure on the outside of the vena cava, the exact same thing will happen as we were talking about with the airways, which is that it will collapse in. And what that gets you is actually a decrease in venous return. So if you decrease your venous return, what will that do? Well, that will probably, in most cases, cause a decrease in preload. And once you have a decrease in preload, you have two options. The decrease in preload will either increase your stroke volume or decrease your stroke volume. And which one of those occurs depends on something that I'm sure you all remember lovingly from school called Frank Starling. Preload and stroke volume. And the way your muscles work, your muscles have chains of fibers that slide across each other. And just like when you're doing a curl at the gym or anything else, there are certain parts of the muscle contracture that are stronger or weaker than other parts. The way I like to think about this is when you first start a curl, it's hard. In the mid-range of your muscle, you have the most power. And then when you've used up all of the chains sliding across each other, you have less power. So in general, increasing your preload, going from here to here, will also increase your stroke volume, going from here to here. But there is a point at which beyond more preload will actually result in decreased stroke volume. So in order to know for sure which one it is, we kind of have to decide if the patient is volume up or volume down, more on the cardiac overload kind of congestive heart failure or more on the volume depletion kind of septic shock picture. In the majority of cases like this, we're going to be over here, and so decreased preload will actually give us a decreased stroke volume. We all know that stroke volume times heart rate equals cardiac output. So if we decrease the stroke volume, we will also decrease the cardiac output, and we will see that as a decreased blood pressure. And this is the reason why positive pressure ventilation, anytime we put a patient on positive pressure ventilation, we need to be aware that we are likely going to have an impact on the patient's hemodynamic status. And for a patient who is already in decompensated shock, that can sometimes be enough to put them into irreversible shock. I challenge you to watch this. Bring a critical patient into the ER, watch their airway get managed, and unless they're paying good attention to the blood pressure and supporting circulation at the same time, many times a critically ill patient that has their airway managed will suffer cardiovascular collapse, often going into cardiac arrest very shortly after that. And this kind of a patient really illustrates the rock and a hard place kind of situation where you have a respiratory failure patient who requires airway management, but they are also in decompensated shock, and you are juggling what to deal with first. You've heard out there, as I mentioned in the December in-service, the concept of resuscitate before you intubate. I would say we kind of want to do both at the same time if we can. And so this is where being proactive with your fluids, being proactive with your Levophed, adding in the push-dose epinephrine, this is where that comes into play. If I can add a little push-dose epinephrine at the same time I'm setting up for my positive pressure ventilation switch, then I can actually support the stroke volume and the heart rate through this, maintain the cardiac output, and prevent that cardiac arrest or that going from a decompensated to an irreversible shock. The take-home point, though, is that anytime you are pushing the air into the chest, generating positive pressure inside the chest, instead of the negative pressure that the patient normally pulls into the chest, you will impact the venous return, and therefore, through these mechanisms, you will drop the blood pressure. Positive pressure ventilation will result in a lower blood pressure. This is, in fact, why hypotension is a contraindication to everything, or to CPAP. So anytime, it doesn't matter whether you're squeezing a bag in, whether the patient's being put on CPAP, anytime you're putting positive pressure into the chest, I want you to be cognizant that that has an impact on the patient's hemodynamic status. And a clinician knows this and is able to anticipate this and take steps to prevent the downstream effects of that.